So good afternoon, everyone, and welcome to Medical Grand Rounds. Before we get started, I'd like to make a brief land acknowledgement. McGill University is on land which has long served as a site of meeting and exchange amongst Indigenous peoples. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which people of the world now gather. Finally, I'd like to invite our Chief of the Division of Nephrology, Dr. Rita Suri, to introduce our invited guest speaker today. Rita?
Thank you, Nadia, and thank you to the Department of Medicine for sponsoring our visiting speaker today, who is Dr. Matthew James. He is professor at the University of Calgary. He originally started his training at UBC and then did his nephrology and PhD at University of Calgary, where he is now a professor. In between, he did do a postdoc at Stanford University. He's a highly successful clinician scientist with more than 200 publications and millions of dollars of CIHR funding, including as nominated PI of the innovative Interdisciplinary Chronic Disease Collaboration. He co-leads the Alberta Kidney Network and the Can-SOLVE CKD SPOR. He has been recognized for his work as an emerging research leader, having received numerous leadership awards, including the Monique Bégin CIHR Leadership Award. His current work is focused on risk prediction models, especially in AKI, as well as computerized decision support and pragmatic embedded clinical trials. So without further ado, I'll hand the floor over to Dr. James. Thank you.
Thank you very much, Rita, and thank you very much to University of McGill for hosting me. It's been a real pleasure to be here and see the nephrology division and everything going on in the program and meet with the trainees. For rounds today, I'm going to talk about research in acute kidney injury, perhaps with a little bit of a different perspective than how we usually talk about acute kidney injury, which is in the acute phase, often in hospital. But I'm really going to talk today about the long-term outcomes following acute kidney injury, what their implications are, and how we might go about improving care for this population. I work at the University of Calgary, and thank you for the land acknowledgement here in Montreal. The land I work and live on in southern Alberta includes the territories of the Blackfoot Confederacy and the Tsuut'ina First Nations and the Stoney Nakoda. And the city of Calgary is also home to Métis Nation of Alberta Districts 5 and 6. These are my disclosures. I have investigator-initiated grant funding related to the topics from these organizations. What I'm going to try to cover today is initially some information to help recognize what the long-term outcomes associated with an hospitalization with acute kidney injury or acute kidney disease is. I'm going to secondly identify some of the gaps in care after hospitalization with acute kidney injury, particularly focused in our data from Alberta, and how these might be addressed to try to improve some of the poor long-term outcomes in this patient population. And then understand how we might use some evidence-based approaches to guide care, particularly with the transition from the hospital to home for people who've had kidney disease identified in the hospital. So this is a paper we published from data in Alberta across our entire province, looking at laboratory measurements of kidney function and kidney disease. And we actually tried to categorize people into the categories of kidney disease that are published in our nephrology guidelines, where we talk about people having chronic conditions, which are defined by reductions in kidney function or evidence of kidney damage for at least 3 months. And this has often been made distinct from acute kidney diseases, which are conditions also represented by low kidney function or kidney damage, but for shorter periods of time. This is defined as less than 3 months. And then our international guidelines, we often talk about acute kidney disease as being a condition defined by days. So traditionally within 48 hours or 72 days or 7 days, sorry. And our current criteria actually, despite this condition being called acute kidney injury, these are all actually functional markers. We always use creatinine or urine output really to identify people. And although we separate these conditions, they're really very related. People with chronic kidney disease are at higher risk for acute conditions, and people who have acute conditions may recover, or they may go on to have chronic conditions. And when we look at the point prevalence of these conditions in Alberta, they're actually very common. There is about 10% of people who undergo a laboratory test in our province every year who are found to meet criteria for chronic kidney disease. So they have a sustained reduction in their kidney function or sustained proteinuria on measurements. But there's also over 5 to 6% of patients who have an acute kidney disease identified every year out of the population. So if you think about this occurring on an annual basis, this is actually a large proportion of the population every year who's newly identified with an acute kidney problem. And we often focus on the management and the poor outcomes of patients with acute kidney injury in hospital. But actually, over the last 12, 15 years, there's been increasing epidemiological data that patients who survive a hospitalization with acute kidney injury have poor long-term outcomes. So this figure here is really looking at the absolute risk in a year after discharge from hospital of a number of conditions. So some of the most prominent risks that have been identified are the risks of cardiovascular conditions, particularly related to heart failure. But there's also a very high incidence of cancer-specific mortality and events. There is the atherosclerotic events themselves as well, all within that cardiovascular conditions. There's also a very high risk of readmission to hospital, both for acute kidney injury over the next year, but also for any reason, not only specific to acute kidney disease in a shorter period of time. And then we have the kidney outcomes. So chronic kidney disease is actually quite common after a chronic kidney disease, and end-stage renal disease in the short period of time is actually not terribly common. It's fairly rare, but this population with chronic kidney disease may go on over time later in life to develop end-stage renal disease at a higher rate than they might otherwise without acute kidney injury. So we've looked in Alberta at trying to understand how people with acute kidney injury are managed after they go home. What sort of investigations and follow-up do they have? So this is some data from Alberta over more than 10 years that's actually followed a cohort of patients identified with acute kidney injury in hospital. And it shows that we actually do a pretty good job of following up their kidney function over time. By about 6 months, almost 90% of patients have had another creatinine to see what their kidney function is. But actually looking for proteinuria, we do much less commonly at the level of the population in Alberta. There are a fair number of patients who get dipstick urine checks, around 50% by 6 months. But in terms of actual albumin to creatinine ratio measurements, these are actually less than 20% even by 1 year in our province. And among common therapies that would be given for people at high risk for cardiovascular disease or kidney disease, including a number of comorbidities that are prevalent in this population, some of the common medications that are known to slow progression of kidney disease or reduce cardiovascular events are only used in about 30% of survivors, 20 to 30% of survivors of acute kidney injury. This is also some more work done by Rachel Jiang from our group in Alberta that actually looked at testing as well as physician follow-up. And most patients, again, about 90% 1 year, will end up seeing a family physician after a hospitalization for acute kidney injury. This is for any reason, not necessarily specific to kidney disease. And in most cases, it's not for that reason, it's for another reason. But the rates of nephrology follow-up are very low. So we tend to only see a tip of the iceberg in nephrology of all the patients who have acute kidney injury, usually the most severe or those who may have been close to or needed dialysis within hospital. And then there'll be a small number who subsequently get referred afterwards. But again, this is less than 10% over a 1 year follow-up period. When we look at the associations with common therapies that we would use to reduce kidney and cardiovascular events after hospitalization, we actually see that there's some interesting patterns of removal of medications in the setting of acute kidney injury and then decisions about their reinitiation or even subsequent new initiation. So this was a study done by Sandeep Brar in our group a few years ago now that looked at ACE inhibitor and angiotensin receptor blocker use after hospitalization for acute kidney injury. And what this study showed is about 40%, so less than half of patients who were on one of these agents before continued their use after discharge from hospitalization if we looked in the next year of their prescriptions. About 13% of people who were previously treated had those medications removed and never started again. And then we had about 7% who were newly prescribed those medications after hospital discharge. So all in all, just around half of patients were still not on these agents. And what we found was that in patients who were newly prescribed these medications, they actually had better long-term outcomes. This was a study where we used a propensity score matching to compare patients who had otherwise similar measured characteristics to those without to look at their outcomes. So the new users and the continued users of these medications had better survival. Those who had prior use and were not continued on those medications actually had a higher risk of mortality. We also looked at end-stage renal disease or progression to kidney failure requiring dialysis. And we found no effect in the new users, but a lower risk in the patients who were continued on these therapies and a higher risk of this in patients who were previously treated but actually had those medications withdrawn. There was a higher risk of hospitalization for a renal cause. This was largely hyperkalemia related hospitalizations in those patients who had new use or continued use. So some interesting observational data that suggests there may be opportunities to optimize care of some cardiovascular and renal therapeutic medications in this population. These effects on survival are actually consistent across a number of ranges of conditions that would be indications for treatment of ACE with an ACE inhibitor or ARB, like having proteinuria or diabetes, heart failure, or established cardiovascular disease. And we see a very similar thing with statins as well. When we look at prescriptions for these agents in patients who have an indication for a statin, be it cardiovascular disease, diabetes, or chronic kidney disease, we again see only about 30% of patients being treated with a statin after acute kidney injury. And again, we see better outcomes in the patients who have new or continuing prescriptions than those who do not. But again, this is all observational data. Another challenging area, and this is actually comes from the voice of patients who go home after being hospitalized with an event that's associated with acute kidney injury. So this is actually very challenging for patients. They often describe that they had other conditions associated with their acute kidney injury that were identified as the priority or the reason for their admission. And so this becomes the focus of their care, usually after acute kidney injury. And there's many studies that show that many patients actually are not aware they had acute kidney injury. So they don't even have the opportunity to mention that to their family doctor. There's low recognition and communication, often from hospital to community providers about these things. That's often different physicians. It's not always documented on a discharge summary. And then there's a lot of anxiety, after a stay in the hospital and returning home about that whole discharge process and care after leaving the hospital, which makes the continuity of care more challenging. And healthcare providers generally describe this as challenging as well. This was another qualitative study from the perspective of primary care physicians in the United Kingdom. They actually identified this as being a very challenging condition for them to understand how it should be managed. They identified real problems in the coordination of care with potentially different subspecialties being involved and where did the kidney issues fit in. And then there was this description of somehow a need to change the way the system of delivering care for this type of a problem where there may be multiple conditions, multiple providers actually comes up. So there have been some attempts to try to see if changing the models of care, augmenting the models of care can improve the transition of care for patients with acute kidney injury and going home after a stay in the hospital. So there's lots of observational literature. I'm going to focus more on 2 clinical trials that have been done in this area, which are both randomized controlled trials, small, but nonetheless provide some interesting information. So this was actually a randomized trial done in Thailand by Thanaphongsatorn. And what they did in this one large hospital in Bangkok is they took patients with fairly severe acute kidney injury. This group had all been actually in a critical care unit. And they actually created a specialized clinic to bring these patients back after hospitalization with acute kidney injury, and they saw them in that clinic. And so they randomized half the patients to actually be followed up in that model of care, and then half patients had their usual discharge out of their tertiary care hospital back to their communities. And in their comprehensive care model, what they tried to do is actually, not just focus on one issue. So they tried to manage cardiovascular disease, diabetes, constellation of the medical issues, as well as the kidney disease and risk factors in this comprehensive care versus the standard type of care model. So this was a small trial really looking at the feasibility, but they did have a few process-based measures that they looked in their study. And the promising ones that they identified was with this model of care, they actually had achieved better blood pressure control, is what they reported in their trial. They achieved the target blood pressures for their patients in about 88% of patients in their comprehensive care model and 58% of those in the standard care model. And although there was no difference in kidney function or creatinine, eGFR between these two small groups, it actually did show that they had a separation in the degree of albuminuria afterwards. So the patients who had better blood pressure control were managed in this comprehensive care model actually showed lower levels of proteinuria. And proteinuria has also been shown to be more common after acute kidney injury, along with hypertension and other cardiovascular risks. So a small, interesting trial suggesting that a targeted approach might improve some measures of care. There's actually a Canadian trial done in this area as well by Sam Silver in Toronto, which piloted a nephrology follow-up clinic in their hospital for patients who'd been hospitalized with acute kidney injury. So they actually screened a large number of patients to identify those who had acute kidney injury, and then randomized them to come back to their AKI follow-up clinics, which was an in-person visit in their hospital, versus usual care, which was their usual discharge process. A challenge with this trial that Sam and his team report very clearly was very difficult to recruit patients into this model of care. So in terms of all the patients that were eligible that they approached to participate, actually 73% of them did not participate in the trial. The most prominent reason being they were tired of returning to the hospital. They already felt they had too many doctors involved in their care, travel time. These were all barriers to want to participate in a trial where you might have this type of model of care done. So in the end, they randomized 71 patients in this vanguard phase. So they were starting a pilot trial and going to use this phase to see if it was feasible to do a larger trial. But they, in the vanguard phase, they had 71 patients randomized to these two arms. So these were their process of care measures. They had about on average, two follow-up visits in the AKI follow-up clinic, and less than half on average in the usual care. So they did achieve some separation. I think about 70% of patients came back at least once to their AKI follow-up clinic. And then they did get more testing of proteinuria achieved. This is just whether they had a test during the 6-month follow-up period. So they did show some improvement in testing for renal risk factors in the AKI follow-up clinic. But overall, when they looked at a hard clinical outcome of worsening chronic kidney disease, dialysis, or death, this was common. It was about 44% in both groups, but no difference between the two groups in this small trial. And then they really described this challenge and actually this model of care. So again, the hospitalization-related fatigue, reluctance to see more doctors, and long travel time was really a barrier that they didn't continue this onto a larger clinical trial after this vanguard phase. So their conclusions was that poor major adverse kidney events were common, but the traditional in-person dedicated model of follow-up posed a variety of barriers. So I'm going to shift gears a little bit now and kind of trying to talk about another more targeted approach. So most of these studies generally took a large group of patients with acute kidney injury and offered something similar to all of them. But we know that individual patients have different characteristics and different risk factors. And we don't always recognize how those things might contribute to the overall risk of an individual and how we might tailor management and follow up according to that risk. So risk prediction models are really the idea that we can use data or information-informed approaches to better understand the risk of our patients. So we can use models for this purpose, and they can be very, as sophisticated or as simple mathematically as we want to make them. But essentially, we use that information to support some decision that we make. So we take some action based on that, and we can actually do this in a more informed way. So instead of treating everybody the same and delivering an intervention in everybody, we can actually separate people out into those who are most likely to have good outcomes anyways, those who are most likely to have bad outcomes that might be the ones we want to invest more effort into addressing, and those in the middle, in the mushy middle, where we're always challenged to figure out what to do. So this is the idea behind risk stratification, and cardiology has been doing this for years and very effectively. And also, this can be helpful for our decision making, because whenever we make a decision, are we going to see this patient again in follow-up or not? Are we going to sign them off our consult service, or are we going to see them back in our clinic in follow-up? We're usually processing a number of different features to make a decision. And often we do this, automatically, intuitively. It's based on our past experiences, and this may work very well. There's another type of thinking called type 2 thinking, which is the more logical, precise, analytical, organized thinking. This is how we're generally first learn our approach to problems in medical school or in residency, for example. That's more methodological. But we often go back to our heuristics or our type 1 thinking. It's easier to use over time. It's reflective. We feel comfortable with it, but it's not always right. For example, this is an easy question. We're very comfortable doing it. We can do it quickly and fast, and we'll get the answer right. But sometimes we actually benefit from more hard, resource-intensive approaches, which are almost always right. So this is not an easy calculation to do. But if we take a systematic manner, we're more likely to get a right answer than our first guess. We strongly prefer doing type 1. We do it every day. We only really do this when we're forced to, or we actually have tools or systems put in front of us to help us do this. So we kind of need to then create systems that allow us to do this. We have lots of data collected in healthcare. We tend to use it to report how we're doing periodically. We publish papers. We often model our data to do that. But this doesn't always feed back into our care decisions, only to the extent we retain it in our memory and apply it on a daily basis. Actually taking predictive models and putting them into care to use that insight prospectively actually requires, systems to put models in front of our use. But now with increasing use of medical records and electronic medical records, I heard last night and this morning how this is a major initiative in Quebec. This has been something our province has gone through to a large degree over the last 5 years as well. We do have these opportunities to try to leverage data-informed approaches more at point of care. And that's the idea behind decision support tools implemented in real time within electronic health record systems. So coming back to how we might apply this in acute kidney injury, we've looked at a couple areas. So I'm going to focus first on this issue of the early intermediary outcomes after a discharge, really around readmissions to hospital, because actually this is not uncommon at all in this population. So this is some work done by Simon Sahani, who's a nephrologist in Scotland. And he actually looked at a cohort of patients hospitalized in acute kidney injury in hospitals in Scotland and did something called process mapping, just to look at what happened in the first 90 days after discharge. So identified how many people got to a GP, how many got to an outpatient appointment, how many ended up back in, this is British, so it's accident and emergency department in the UK, or were readmitted or died within those first 90 days. And what he actually found is that the thickness of these lines really represents the proportion of patients in each group. But there's actually a very large group who ends up readmitted or dying before they even see a family physician or have any laboratory testing or ever get to a specialist, or before they end up in an emergency room. So really, this would need, awareness really very early after discharge of a patient being at high risk to try to intervene in this process. So he looked at prediction models for readmission in patients with acute kidney injury to see how well models that had been developed in Scotland applied to patients with acute kidney injury in his cohort. And what he found actually is they tended to underestimate the risk, but with some recalibration, they could actually be used to perform very well to actually predict the risk of readmissions among people with acute kidney injury. And this is something called a decision curve analysis. So what it does is measure something called a net benefit, which is a trade-off between making decisions based on a criteria, based on the trade-off between the true positives and the false positives. So every time you make a decision based on a true positive, there's potential to benefit, but the trade-off is if you make a decision based on a false positive, you do something unnecessarily or inappropriately. So he compared using a risk model to guide follow-up versus criteria like taking all patients who had acute kidney injury, those who had a discharge GFR that was low based on the severity of acute kidney injury. And with these decision curve analyses, you're really looking for the highest net benefit across the range of predicted risk to be the ideal decision-making strategy. And so this dotted line here is the model-guided approach that's actually really suggesting, at least from this perspective, that making clinical decisions based on the model has the greatest potential for net benefit than these other type of simple strategies we might use. In Canada, we've used, in a lot of centers, we've used the LACE index to predict readmissions. This was developed in Ontario using a prospective cohort there and validated in a large registry, large administrative data set in Ontario. And it uses the length of stay, whether this was an emergent or acute hospital admission, a measure of comorbidity, and the number of visits to an emergency department in the last 6 months to predict a patient's risk of readmission within 30 days. And it performs very, very well in Canadian cohorts. We look to see whether this would actually work in patients with acute kidney injury in Alberta as a prediction tool. You can see that the patients hospitalized with acute kidney injury are older than many other patients. They tend to have longer hospitalizations, higher acuity. They're in hospital for longer. And on average, they have a higher LACE score than the general admitted population in Alberta. But this is a calibration plot, comparing the predicted and observed risks using the LACE score or a predicted risk from the LACE score. And actually, we found this tool works very well for patients with acute kidney injury. So it provides an opportunity that you could guide the care or the follow-up strategy according to a LACE score for a patient. The other area we've been interested in this is for the kidney outcomes related to acute kidney injury. So chronic kidney disease after acute kidney injury. So there's a lot of variability around this. So it's not the same for all patients. We will all see patients who have acute kidney injury hospital and they have a very good degree of recovery and they can do very well. We see much less commonly those who have severe acute kidney injury. They go on to require kidney replacement therapy and they don't recover. These are usually patients who have chronic kidney disease to begin with. And then we see a number of kind of intermediaries, some degree of development of chronic kidney disease afterwards, and the cardiovascular risk that goes along with that, and some progression of chronic kidney disease afterwards. So there's this spectrum in an individual patient of what their long-term kidney disease might be. And several years ago now, we actually surveyed nephrologists about which patients would they bring back to their practices to follow up after a hospitalization with acute kidney injury. And we gave physicians a number of scenarios. And there was a lot of variability around this, but there were a number of conditions where, the nephrologist thought this was concerning, and on a survey, they said they would be prone to bring these patients back and see them. But actually, in observed practice, the rates of follow-up were much lower and highly variable. So we developed a model to try to address this. So it was a model for people who were hospitalized with acute kidney injury, who didn't have advanced or severe chronic kidney disease to begin with. And then we were looking to see, did those patients go on to develop chronic kidney disease afterwards? So we developed this in a cohort of routinely collected data from Alberta, and then validated it in a cohort from Ontario. And in the end, we came up with in a number of different models, but this is a 6-variable model that was the best in terms of a trade-off between the predictive ability of the model and the pragmatic, or making something practical that didn't have too many variables to be implemented. So the predictive variables are really associated with higher risk of developing severe chronic kidney disease, were older age, female sex, lower levels of baseline kidney function before hospitalization, the presence of proteinuria, the severity of acute kidney injury, and then the degree to which kidney function had recovered at the time of hospital discharge. So if we put all these 6 factors together, we could get a range of risks, predicted risks for individual patients that range from very low to less than 1%, all the way to high risk patients who are over 20% or even higher risk of having advanced chronic kidney disease. Here, this is patients who have a GFR that's less than 30, that's sustained for at least 3 months, or go on to require kidney replacement therapy, dialysis, or a transplant. And this performed very well when we validated it in Ontario, so it looked like it could be applied and had some generalizability. And again, we did this decision curve analysis type of approach to compare decision-making based on a risk score versus following everybody, following only those with severe AKI, using a discharge creatinine. And again, the curve for using the risk model was the approach that had the most potential to be beneficial for guiding treatment decisions related to needing care for chronic kidney disease later after hospitalization. So that allows us to start, risk stratifying people. You could come up with you can recognize what the positive and negative predictive values are at certain thresholds of risk, and start developing a follow-up strategy based on risk with this type of an approach. We were left though wondering, well, what is the thresholds that we should actually use to try to make some of these decisions? So we did another survey. We created basically a number of scenarios. Again, we've varied the individual patient characteristics across a range of these risk profiles. And then we gave these vignettes to nephrologists. So if anybody completed this survey last fall, thank you for doing that. We distribute it through the Canadian Society of Nephrology here in Canada, but also to nephrologists in the USA and the UK as well. So they were asked how likely they would bring this patient back with these characteristics for a follow-up nephrology visit, with responses measured on a 7-point Likert scale. And the other aspect that we did, we were interested to actually see how much did actually providing the predicted risk influence any decisions. So we actually randomized the nephrologists to get a version that just gave the individual patient characteristics. And then another half of the nephrologists would actually get the predicted risk of having advanced chronic kidney disease given to them to see if that helped, change their decision-making. So we had 171 nephrologists complete this survey from across those 3 countries. Most practiced in an academic center, about 80% of them. And this actually shows the range, or the distribution of Likert responses. So the darker orange here is moving up towards, I definitely would bring this patient back and see them in my clinic. Getting darker blue is I definitely wouldn't. And then these are the ranges of the predicted risk of advanced chronic kidney disease across the scenarios. So you can see that there is a range that occurs, the nephrologist's opinions did differ according to this risk threshold, and identified the patients at higher risk who they would prioritize to bring back to dedicated clinics for follow-up. And they would do this much less likely in patients who had lower predicted risks of advanced chronic kidney disease. When we broke this down by whether they saw the risk score being reported or no risk score being reported, we actually found this gradient was much clearer, much more evident when that risk score was reported along with the clinical information. There was you can see much more variability here across the responses when you didn't get the risk score. You had to put together all of those individual characteristics to make a decision. And if you model this out, there's kind of an interaction of the slope here. So the effects are opposite and largest at either extreme. So the risk scores are more likely to suggest to seeing the follow-up at the higher risks and less likely to respond with seeing the follow-up at the lower risks. So it does seem like a tool that even if influences nephrologists' decision-making on top of just basic providing all the individual clinical parameters. So when we come to think about, well, what is the evidence base for using a risk prediction model in clinical practice? There's really kind of these 4 stages that are commonly described. First of all, you work on deriving a model and optimizing its performance and trying to improve it if you can. Then really there's the step of trying to understand how well it performs in an independent new external population. So ideally we want to externally validate things to know that they're generalizable. Then there's the challenge of, how are we going to implement them into care? How are we going to achieve that? And then what is the actual clinical impact? So we did a small pilot trial in Alberta to try to understand how we might use the risk score and whether we could use this to try to optimize care. So what we did is did a randomized controlled trial of patients admitted to medical services in major hospitals in Alberta, where we compared just the usual discharge process that occurred on those wards to patients actually having the enhanced discharge process, where we actually performed the risk stratification just before patients were discharged home. And we put them into these risk strata of being at low, medium, or high risk. Here we used over 10% of advanced chronic kidney disease. And then we actually just focused on doing follow-up appointments on the high risk, this group with the high risk condition. For those with the medium risk condition, we sent a guidance document and a link to a CKD clinical pathway to the primary care provider. And then we just told the patient they were in a research study if they were in the low risk group. And we really just focused on seeing if the care was any different. So we really focused on medical management. So statin, ACE, and ARB treatment for patients with CKD guideline related conditions for these medications. And then whether the patients who did go on to have category 4 chronic kidney disease did end up seeing a nephrologist during their follow-up process. So we actually ended up randomizing 155 patients. We had 79 in the enhanced risk stratified guided care arm, and then 76 in the usual care. And we used routinely collected data as well to augment our follow-up. We have a provincial pharmacy database, so we're able to capture all outpatient prescriptions as well to measure these outcomes. So we had very good ability to follow up these patients. And they tended to be a mix of patients with a range, almost a third, but in terms of across the risk score, very high prevalence of diabetes and cardiovascular conditions and hypertension, and about 30 to 40% of patients on statin or ACE or ARBs to begin with. And what we found, though, was with this enhanced model of care, we were really focused on bringing back these patients and providing this specific advice. We did see a 16% increase in the proportion of patients who were prescribed an ACE or ARB, an 18% increase in statin prescription in this group, and in the small number of patients who did go on to have advanced chronic kidney disease, we did have more of these patients seen in follow-up by a nephrologist coming because they came through these clinics. So we're able to find actually this model of care did result in some differences in the processes of how they were cared. We started this trial before the pandemic, and actually we focused on renin-angiotensin system blockers and statins based on most of the evidence we had at that time. But we have a lot more evidence now for cardiovascular and renal protective medications that we could even apply to something like this that we didn't study at that time, with the addition of SGLT2 inhibitors and the non-steroidal mineralocorticoid receptor antagonists now. The other thing that's happened for us in Alberta as we came to the end of that pilot trial was the arrival of a new provincial clinical information system. So we implemented EPIC starting in 2019 in Alberta, and we're just finishing off the provincial implementation across all these 9 health zones in Alberta now, and starting to use this system. So we decided to actually change a lot of the way we did this and really create a trial that was embedded in the electronic medical record system, and actually provided a tool that we could then use to guide follow-up and test this in the trial. So we actually have now developed and just starting 2 related trials that use those risk models for readmission to hospital and risk of chronic kidney disease to guide follow-up. So they are embedded and built into our EMR system and executed on patients who are admitted with acute kidney injury. And then we have 2 types of interventions based on the risk score for those with very high risk of hospital readmissions based on the LACE score. They get those who meet those criteria in this trial will be randomized either to usual care or getting a virtual home hospital model of care, where we do some remote monitoring and virtually care for patients at home. And this is to try to overcome that challenge of coming back to the hospitals being very undesirable for patients who've just come out of the hospital. And then for those at very high risk of chronic kidney disease, they also get some augmented nephrology follow-up. So those just at that very high risk of predicted chronic kidney disease are really targeted for this intervention. So we're doing this in a pragmatic manner. So pragmatic clinical trials are a little different from the traditional clinical trials. They're really designed to be informed decision-making and a balance of different models of care or different health system interventions really embedded into the way we deliver clinical care and in a much more practical way than traditional clinical trials. So they tend to ask questions like, can an intervention work under our usual conditions or the way we currently deliver care, versus can an intervention work in ideal conditions like we tend to set up traditional clinical trials for. So these trials tend to be more clinically and policy focused. They're much more focused on real world types of treatments with more flexibility in terms of protocols and customization than rigid trial protocols. They tend to try to have broader general eligibility criteria to be more representative to the population at risk. We try to identify measures which are clinically relevant, but can be easily collected in clinical settings to reduce the additional burden of measuring clinical outcomes. And ideally, they're designed to be relevant to everyday practice. This is one example of a tool that kind of goes through a clinical trial to understand how pragmatic it is, because it's really not true that trials are pragmatic or explanatory or traditional. There's really a continuum. So you can have, various degrees of pragmatic eligibility criteria, recruitment processes, design of how you deliver your intervention and measure your outcomes. This is the Précis tool that can be applied to a trial to try to understand that. I've really covered that. The other thing that's been really critical for us to do this in Alberta is really having a network to work with in terms of getting these tools implemented and understood in operational areas. So one thing in Alberta is we have a strategic clinical network that includes on these groups and trials that we're doing, we have patient advisors, but also operational leaders and researchers, partners from all of the stakeholder organizations who help us implement these processes in the form of the trial. And we have a medicine strategic clinical network in Alberta. And this is really the design of the trials, where we actually embed as much of this as we can into the electronic medical record. So our algorithms to find patients with acute kidney injury at high risk of chronic kidney disease or high risk of readmission are programmed in. And so we can actually build alerting systems to find these patients, and then even automatically randomize them to get different forms of care from the system. So they then can get prompts to their providers to refer them to a specific service, or prompt back to the family physician, who then gets a standard discharge summary, specific guidance related to their follow-up based on their risk and clinical indications for different forms of care. And this is all kind of built around these risk stratification tools. And this is just applying that Précis tool to our trial. We've tried to make this very pragmatic, and for most cases is really, other than the fact that we have redesigned some of our follow-up processes in nephrology and with our pharmacist services, really to try to target this a little bit more uniquely than we currently do in usual care. So really the idea behind this is, with these trials, we hope to try to understand, at least in the context of the transition from acute kidney injury home to the community, whether we can change our model of care in an effective way. So right now, instead of treating all patients in a very consistent way, where after acute kidney injury, actually in Alberta, we have quite low awareness of acute kidney injury and focus on identification of cardiovascular risk and cardiovascular risk reduction. We could have a system where we're much more tailored and targeted based on the individual risk of a patient, where we actually apply these things in the discharge process and have tailored pathways to care. Some of them coming back to nephrology, some of them coming through virtual home hospitals, and some of them still operating through primary care. So I'll just wrap up here with a few conclusions. So, we do have some validated approaches that can be available and used already today to risk stratify patients with acute kidney injury. If you're discharging a patient and deciding, whether they should have early testing of kidney function and follow up with a family doctor if they're at high risk for hospital readmission or death, or if you have an early follow-up clinic or discharge clinic, you might apply this to a patient. And we do have models for patients with severe chronic kidney disease, where you may want to consider ensuring that follow-up for kidney disease or even referral to nephrologist services might be considered. So I think we can use these tools. We hope to test this in Alberta to determine if we can develop more appropriate and efficient follow-up care pathways for patients that can overcome some of these gaps in care and transitions from the hospital to home. And then, where we're now at is we're hoping that with these further research studies, we can really refine our understanding of whether these types of targeted interventions work and what components are effective and what is that effect on long-term clinical outcomes. So this is our research group at the University of Calgary, who's working on all of this work, and part of our larger nephrology division research group that works with the Alberta Kidney Disease Network and the Interdisciplinary Chronic Disease Collaboration, who really makes all this work. And thank you to these funding organizations and partnerships across Canada and Alberta to support this work. And I'll stop there, and happy to take some questions and discussions. Thank you.
Thank you, Dr. James, for sharing your work with us. It's very interesting what you're doing. Are there any comments from the crowd through the chat? I'll start with a question while we're waiting. Natty?
Go ahead. Yeah, so just a quick question. Congratulations on this work. So I guess ultimately to get to, make this, everyone to use what you're trying to do here, what do you think the greatest barrier to advancing? Is it going to be the patients, the clinicians, or the sort of funding, Alberta Health? Because there's great potential. Obviously, you're showing that you can make a difference. To get this widely implemented in Alberta and in Canada, what's going to be your biggest barrier?
Yeah, I think there's barriers all along all those large domains that you mentioned. I think our EPIC implementation is at a level now where we couldn't have done this initially. It's taken some time to be able to build and pull data effectively out of the system. So there is an IT barrier that I think has existed that we're slowly, it takes time after these implementations to be able to start achieving meaningful use of these systems. So I think that's kind of one barrier that takes a bit of time when these systems first get implemented to recognize. The patients, the work from Ontario really identified the patient barrier. I didn't talk a lot about the co-design work we've done, but one thing we've tried to do in designing these interventions and the rationale for them and how we present them to patients is actually work with patient partners in that process. So some of these algorithms actually, there's material that comes out of the EMR that's given to patients when they go home. So we provide information about, why there's this recommendation and what it involves and why that's being suggested to help the education for patients and awareness. So that makes it more, we hope, more acceptable to patients, and our patient partners tell us that the why is important to know when you're trying to do these sorts of things. And they also have, evidence behind them that this sort of strategy for facilitated relay can actually be quite effective, where you kind of give the information to the patient and they can take that back to their physician, and relay the information back to primary care as well. And then I think, the physicians and the changing behavior in clinical care is a real challenge as well that has to be, thoughtfully done. We're fortunate to work with some very good system design people who, take decision support principles and really think them through of how you develop these decision support strategies and more effectively nudge, towards the things you're trying to promote, and make the decision support less intrusive. We all get frustrated from alerts that feel like they're low value and interruptive and intrusive, rather than delivered at the right time when you're in the system trying to make that decision. So trying to have these tools come up at the right time in a discharge navigator when medication reconciliation is being done or the referral appointments are being submitted into the system. Those kind of things I think help. And then, just a big opportunity that this has been, is the fact that we have now from these tools, we have this standard discharge template and information that can get out to primary care in a consistent way. So we can start to have more consistent information get out into the community and the primary care. So at least some of the, there's those informational communication barriers between hospital and home that are a huge challenge to trying to do this. And so having this system where those informational continuity, communication continuity carries through is important. So I think working with the, taking the perspective of all the stakeholders, I think has been, we've been trying to do that and incorporate. Yeah.
Andre?
For the patient who appeared who has AKI, but previously had normal renal function, if such a person still exists, so then they're, they recover, or to some extent. So in this group that recovers, what's the indication for, say, ACE inhibitors and other medications? And like if they recover to supposedly normal renal function, I don't think we would give those people drugs, right?
Right.
So where's the cutoff?
Yeah.
I'm just gonna
Okay.
paraphrase.
Oh, yeah.
So
Okay.
the question was regarding indication for ACE inhibitors, SGLT2 inhibitors, et cetera, in the post-AKI patient who has recovered or partially recovered, and where's that evidence?
Yeah, that's a great question. Sorry. Yeah. So we are not proposing that a unique AKI specific indication comes up for these patients. There's actually such a high prevalence of diabetes, chronic kidney disease, and cardiovascular disease in this population that actually these are actually our triggers that kind of guide the subsequent medical management and recommendations. So I suppose like a young patient who doesn't have any of these conditions and fully recovers and has no proteinuria, our pathways wouldn't promote, adding an ACE inhibitor or angiotensin receptor blocker for that. But we do see, even in this group who have these comorbidities and these indications, we do see these lower than prescribing gaps. And interestingly, we see this lower in the in our AKI group than our CKD and diabetes population. So we think there's like this residual kind of care gap, at least in Alberta, that we could close it.
I imagine from what you said, that time is an important factor in getting patients on the right treatment, the right patients on the right treatment. Here in Quebec, we have a large and growing problem with delay getting access. And I'm wondering if your systems have had to cope with this and how much your experience has been in managing delay for these patients.
So the question was how to deal with these increased follow-ups required for AKI patients, given long waiting lists to see a doctor for that.
Yeah. So we realized the same thing, that we couldn't bring, if we were trying to do something more timely, particularly for these higher risk patients, we couldn't put them into our standard nephrology triage process. So we actually separated it out, and are in the context of this study trying to do something more timely. We have a bit of a variation in the time frames depending on their risk of readmission. So the very high risk patients, we're trying to see them within 2 weeks, and the ones that are higher risk for the CKD related outcomes, not so high risk for the readmissions, we have a longer kind of target for their follow-up. But yeah, that is an issue. Getting back in to see a family physician, is challenging as well, timely after a hospital discharge. I know in our institution, we always just write, see your family doctor in 1 week, after, which isn't often feasible for some of our patients. So we're trying to build in, that's why on that Placey tool, it's not entirely pragmatic, because in the context of doing this, we are trying to adapt the way we follow patients a little bit better.
There's a couple of questions in the chat which are related, and so maybe I'll sort of integrate my question into that. So I think it's outstanding how you've been able to harness the new Epic EMR, embed the clinical decision support, and then roll out all of this, these interventions. But I guess my question is were the stakeholders already somewhat on board with you, or was that an uphill battle to get sort of IT administrators, family doctors, community stakeholders involved in this? What sort of hurdles did you face, and how did you overcome those?
Yeah, it's an important point. It has taken time, and I think it would be great if we had more capacity to do this type of work, but I think having an organization like the Strategic Clinical Networks for us is really helpful, because it allows us to quite effectively get decision makers and clinicians in rooms together to do this type of work and establish some consensus and plans for how it will be implemented, to bring patients into those processes as well. We did have to, it's taken us longer to build all of these tools that are kind of tailored and into the system.
And do you have ethics? Like, is it an opt-out, or could you comment on that?
So we do have, it depends. So we actually have, there's a component that we have for some elements where we have there's really 2 trials embedded within this. And one is a waiver of consent granted by our ethics board, where it's just decision support prompts going to a physician who has the decision to accept, or they can override them. Then we have another trial in here where it's informed patient consent. So it's a little, that one is a more intensive intervention, where there's actually we felt the need for the informed patient consent element to be done.
Okay, so we have to vacate the room now, but Dr. James will be available outside if people want to chat with him afterwards. Thank you very much for coming to Montreal, to McGill, to present your work.
Thank you.